Postpartum hemorrhage may be primary or secondary. Primary postpartum hemorrhage refers to bleeding of more than 500 milliliters from the genital tract within the first 24 hours of delivery, or any amount of blood loss that results in hemodynamic compromise of the patient. It usually occurs during or immediately after the third stage of labor. Secondary postpartum hemorrhage is defined as excessive vaginal bleeding occurring from 24 hours to 6 weeks after delivery, and the delivery may occur with the placenta retained or after its expulsion from the uterus. So, but postpartum hemorrhage becomes life-threatening if the mother is already anemic, and the blood loss of more than 500 milliliters may lead to shock. So, the causes are uterine atony usually in 70 to 90% of cases, retention of all or part of placental tissue within the uterine cavity, infection within the uterine cavity, as endomyometritis, and genital tract trauma, clotting disorders. The main symptoms are excessive or prolonged vaginal bleeding after delivery and low abdominal pains. Signs that are usually elicited are active bleeding from the genital tract, conjunctival pallor, and also rapid pulse. Blood pressure may be low or normal. Deterioration of maternal levels of consciousness, flabby, poorly contracted uterus, obvious tears in birth canal or perineum, and also obvious retained placenta and suprapubic tenderness. Investigations are FBC, circling status, bedside clotting test, blood grouping and cross-matching, ultrasound scan if patient is stable, to check for retained placenta tissue. The main treatment objectives are to identify the cause and stop bleeding as quickly as possible, and also to correct hypotension, to correct resulting anemia. Non-pharmacological treatments. So due to uterine atony, that's postpartum hemorrhage due to uterine atony in 70 to 90% of cases, and also with no placental retention. You massage fundus of uterus to stimulate contraction, and encourage woman to empty bladder or pass a urethral catheter to empty the bladder and monitor urine output. Also by manual compression of the uterus and balloon tamponade if uterus fails to contract with massage. For postpartum hemorrhage due to retained placenta, you attempt to remove off the placenta by controlled contraction as soon as a contraction is felt. As if not successful, await the next contraction and repeat the procedure. If the placenta cannot be expelled in this fashion, manual removal under anesthesia is indicated. If the placenta has been delivered and is incomplete, exploration of the uterus and manual removal under anesthesia is indicated. If the facilities for manual removal of placenta under anesthesia are not immediately available, you refer to hospital. Bleeding with the uterus well contracted and placenta completely delivered. So examine the patient in the lithotomy position with adequate analgesia or anesthesia, and good lightening to identify and suture perineal, vaginal, and cervical tears. If the tear or tears extend into the uterine body, effective suturing cannot be performed, and repair will involve a laparotomy. For ruptured uterus, repair or hysterectomy is required. Or bleeding associated with coagulopathy, bedside clotting test, 5 milliliters of blood placed in a 10 milliliters round bottomed glass tube should clot in 6 minutes. The pharmacological treatment if the uterus is poorly contracted, as a 21st line treatment, you give oxytocin IM 10 units start, and then oxytocin IV infusion 10 to 40 units in 500 milliliters dextrose saline or 0.9% or normal saline. Dose not to exceed 40 units. If intravenous oxytocin is unavailable, or if the bleeding does not respond to oxytocin, and the second line medications are recommended. So second line treatment, we give misoprostol sublingual 600 micrograms for postpartum hemorrhage prophylaxis within first minute of delivery, and misoprostol sublingual 800 micrograms start if patient is conscious for as well postpartum hemorrhage treatment. Or third line treatment, you give agometrine IV 500 micrograms start or oxytocin agometrine IM as a drug combination, oxytocin 10 units and agometrine 500 micrograms start. Or you give oxytocin misoprostol starts oxytocin IV 10 units and misoprostol rectal 600 micrograms. High rates of adverse effects like nausea, vomiting, and high blood pressure occur in women treated with agometrine. So they should not be given to women with hypertension in pregnancy or heart disease. For protracted bleeding uncontrolled by oxytocin and other uterotonics, or if bleeding is due partly to trauma, you give tranexamic acid slow IV. You should not exceed 100 milligrams per minute. We give 1 gram start and then 1 gram 8 hourly with a maximum of 3 grams in 24 hours. For hypovolemia, if sodium chloride 0.9% or Renget's lactate IV and blood transfusion as clinically indicated. Anesthesia for manual removal of placenta, you give morphine IV 2.5 to 5 milligrams start as required if no anesthetist is available, or petidine IV slowly or IM as 1 milligram per kilogram 6 to 8 hourly as required with a maximum of 100 milligrams per dose. Also diazepam slow IV 5 to 10 milligrams 8 hourly as required, not more than 2.5 milligrams per minute. We do not mix petidine and diazepam in the same syringe. We monitor respiratory rate of patients closely. We stop drugs if respiratory rate is less than 12 breaths per minute. We can also give ketamine IM as 5 to 10 milligrams per kilogram start, or ketamine IV 0.5 to 2 milligrams per kilogram start. Ketamine must be used only by trained medical officers or anesthetists. We provide antibiotics prophylaxis after manual removal of placenta or exploration of uterus or repair of birth canal tears. So secondary postpartum hemorrhage, give oxytocin IV infusion 20 units in 1 liter of normal saline, or agometrine oral 500 micrograms 8 hourly for 3 days. Also antibiotic prophylaxis, we give amoxicillin oral 500 milligrams 8 hourly for 7 days, and metronidazole oral 400 milligrams 8 hourly for 7 days. The referral criteria: so refer patients who do not respond to the treatments mentioned to a specialist, and also refer promptly to a hospital with theater and blood transfusion facilities for examination under anesthesia or laparotomy if these are not immediately available. Let's look at a quick flow chart. So postpartum hemorrhage, blood loss 500 milliliters or more, you call for help. Massage uterus as a tony is most likely cause. Start IV fluid resuscitation. That's normal saline or Renget's lactate or dextrose saline, 1 liter in 15 minutes. You take blood for grouping and cross matching. That's 2 units. You administer oxytocin units as IM start, followed by infusion of 10 units in normal saline or dextrose saline or Renget's lactate. As empty bladder and monitor urine output. If profuse bleeding continues, identify causes. If yes, is the placenta out and complete? If no, you perform manual removal of placenta under pethidine and diazepam anesthesia if trained. And also continue with resuscitation and oxytocin infusion. You monitor BP, pulse, urine output closely, and organize donors. Also refer to a hospital. If profuse bleeding continues, identify causes. If yes, is the uterus well contracted? If no, you perform bimanual uterine compressions. If unsuccessful, you insert balloon tamponade or tamponade, and then you give other oxytocics, for example, egometrine, misoprostol, and you give IV tranexamic acid. Then you continue with resuscitation and oxytocin infusion, and you monitor BP, pulse, urine output closely, and you organize donors and you refer to a hospital. If bleeding continues, you identify causes. If there is no and is coagulopathy observed, if yes, you give IV tranexamic acid, then you continue with resuscitation. And if the bleeding if there is profuse bleeding and if that continues, you identify causes. And if the answer is no for this, are there obvious tears in the vaginal cervix? If yes, use suture tears under local or general anesthesia. And from there, you continue with the resuscitation and oxytocin infusion. Then you monitor BP, pulse, urine output closely, organize donors, and refer to hospital. So at the referral hospital, you perform examination under anesthesia to identify and treat causes. You perform surgery, lynch, uterine repair, hysterectomy as needed. You correct shock, you check BP and correct anemia, and blood transfusion if needed. When bleeding is controlled, you give prophylactic antibiotics. You monitor closely for 24 to 48 hours, and you review after discharge for anemia, sepsis, and other long-term as a sequelae of severe postpartum hemorrhage.